The following is a presentation on Charge syndrome done by Kathy Reynolds, Katie McGue, and Grayson Wilson. Charge syndrome has a prevalence of less than 1 in 10,000 births. Children born with Charge syndrome have a 70% survival rate. The syndrome is caused by either a mutation or a deletion of the chromodomain helicase DNA binding protein 7 or CDH7. Charge does not discriminate on who it affects. It has been reported across all races on every continent. A study done by Tellier et al. Revealed that paternal age, not maternal age, may be a risk factor for the mutation. Charge includes a variety of anomalies and can be accompanied by scoliosis, renal anomalies, limb or bone anomalies, dental anomalies, cardiovascular malformations, central nervous system anomalies, and more. The acronym CHARGE stands for coloboma, which is a cleft of the iris, heart defects, choanal atresia, which is a blockage of the nasal passage by excess tissue, retarded growth and development, genital abnormalities, and hypoplasia or incomplete development of a tissue or organ. The last letter of the acronym stands for ear anomalies and deafness. To qualify as somebody with Charge, a child needs to have 4 major components present, or 3 minor components present and 3 major components present. The major components include coloboma, choanal atresia, cranial nerve dysfunction, and ear anomalies. Minor characteristics include genital hypoplasia, cardiovascular malformation, development delays, growth.
Language for those with Charge syndrome isn't an easy feat. About 60% of these individuals acquire symbolic language over time. This includes the use of gestures, American Sign Language, and/or meaningful vocalizations. If a child does not develop this language use, it becomes very difficult for them to express their wants and needs. Parents tend to have a difficult time knowing whether their child's actions are meaningful, as children who are severely impaired show many pre-intentional behaviors that come in high repetition. Also, with the presence of these behaviors, it is difficult to know if these children have receptive skills, which means skills demonstrating their understanding of what is being said to them. If a child with Charge does in fact incorporate speech or vocalizations into their language, the biggest concern becomes their intelligibility. Because of their craniofacial anomalies, it is very difficult to accurately articulate, thus making them highly unintelligible. Those with Charge also have a difficult time turn-taking and maintaining topics while in conversation. As those with this syndrome tend to have high anxiety, it is extremely beneficial to create routines within a day or tasks with high repetitions. With all these difficulties that have been just stated, it is found that communication is one of the highest causes for behavior outbursts in these children. Swallowing is a major difficulty for someone with Charge syndrome. Directly at birth, they tend to require a feeding tube because of their poor suck and swallow coordination, which is needed for them to eat. This is caused by a neonatal brainstem dysfunction, and this happens in about 96% of the cases with Charge. A child born with Charge typically has a sucking and swallowing disorder as well as an esophageal dyskinesia. Both of these symptoms result in poor sucking ability, prolonged feeding time, milk aspiration, which is when milk travels down the windpipe and into the lungs, unexplained cries during bottle feeding, nasal reflux, regurgitation, and apparent life-threatening events during feeding. These results are very dangerous for a baby to endure, as they can cause pharyngeal congestion, aspiration, pneumonia, and/or failure to thrive. Charge syndrome causes a defect of multiple nerves in the body. While looking at feeding and swallowing, there are facial nerves that are defected that limit the child's ability to use their face and/or lip movement to successfully use a sucking motion for feeding, and this is called facial palsy. Unfortunately, it appears to have very little improvement with age. These children tend to be born with multiple malformations of the esophagus, larynx, and palate and lip features. These anatomical malformations also play a role in the inability to suck and swallow and also affect their ability to breathe. Many are born with a cleft lip where there is no lip closure possible, or a cleft palate where the hard palate is not fully formed. Because of this, they have no way of closing off their nasal passage, which would allow liquids attempting to be swallowed to come out the nasal cavity. Swallowing difficulties may be improved by implementing soft and largely perforated nipples with thickened milk. They would also benefit with small meals and any avoidance of force feeding the child. If the child has a bad experience with swallowing food, they may become scared to eat and a feeding tube will have to be integrated again. Both language and feeding should be addressed early in a child's life to increase their quality of life later on.
Students with Charge syndrome benefit from speech therapy services to expand their receptive and expressive language abilities. social skills, and in some cases, speech production skills. SOP should look at a child with Charge syndrome as a whole person, taking into account not only structural, anatomical, and physiological characteristics of the syndrome, but also positioning, sensory needs, and behaviors of the child. When it comes to working with children with Charge, a total communication approach works best. This means incorporating spoken language, vocalizations, objects, tangible symbols, body language, gestures, sign language, photographs, and written text into therapy and their everyday lives. The purpose of total communication is for the SOP to convey information to the student that the student can then use to communicate with. Sign language is often the easiest for a child to learn first, and it should be stressed to the parent that learning sign language does not particularly mean that their child will never learn to speak. Many times, a child with Charge is unable to complete a task because the features of the syndrome get in the way. This can then be interpreted as non-compliance or lack of understanding, and it is our job to be able to identify that it is actually neither. There are many intervention approaches an SLP can use when working with children with Charge syndrome. One includes adapted prelinguistic milieu training. APMT incorporates the strategies of delayed prompting, modeling, and environmental arrangements to elicit vocalizations and natural gestures. This modified intervention is appropriate for children who are deaf, blind, or both. The adapted version includes limiting vision and hearing activities, increasing vestibular and tactile activities, and using physical prompts, including hand under hand and tactile prompts. Body orientation and searching behaviors demonstrated by the child can be interpreted as eye gaze and as a sign of an intention shift. One study done included a male patient with Charge syndrome beginning APMT at the age of 5 years. At 13, he was demonstrating functional communication behaviors by using signs, gestures, and visual symbols. A second therapy approach option includes the teaching of cued speech. This is appropriate for those children that are hard of hearing or deaf. It is a mode of communication that allows children to use their hands to spell out the sounds in a word. 8 different hand shapes are used to represent all consonants, and movements near the mouth are used to represent vowel phonemes. This technique allows children to learn to read and write in the same way that hearing children can. This teaching of phonemic awareness gives children a greater understanding of what they are reading. Academic and literacy gains have been reported with the use of cued speech.
Positive behavioral supports can also be used as a therapy technique for patients with Charge syndrome. A study was done that included 6 deaf-blind students, one of which had specifically had Charge syndrome. This patient was female and 21 years old and participated in the study for 9 months. The study of the positive behavioral supports included preventative supports and supports during behavioral episodes. With the Charge participant, the teachers used adult-like language, environmental engineering to ensure smooth transitions, and sensory motor integration. The participant did have hearing capabilities and benefited from sensory distance, such as being outside of the music room rather than inside to enjoy music class. After the 9-month study, the participant had less challenging behaviors and better self-regulation. An excellent resource for anyone interested in learning more about Charge syndrome and resources for anyone affected by the disease or tips for therapy would be the National Organization for Rare Diseases.org page. The following are sources included for this presentation, and now is a demonstration on therapy techniques for a patient with Charge syndrome. So patients with Charge syndrome can have a variety of anomalies affecting their communication. This can include being blind, being deaf, or being a combination of both. We will demonstrate an enhanced milieu teaching technique called incidental teaching, specifically environmental arrangements using this water bottle. Environmental arrangements, we will arrange the environment to increase communicative acts with examples of all 3 types of patients, one who's blind, one who's deaf, and one who is a combination of both. So first we will begin with a blind patient who is a prelinguistic, preschool age to kindergarten age with no verbal communication and little to no gestural communication. So using environmental arrangements with a patient who is blind, you're blind. Okay. You could use this technique by creating noise where a patient would recognize where the water bottle is and have to exhibit a communicative act such as a gesture reaching for the water bottle. Good job. Thank you.
Thanks.
Okay. So in this case, our patient will be a deaf patient, but we will still have the visuals and we'll be looking for eye gaze, any form of communicative act with eyes. So, for example, a child with charge syndrome that you have here in therapy, to engage them, we could shake the water bottle. Even though they don't have that auditory stimulation, they can still see. Playing with the water bottle, this is fun, this is exciting. And then stop. And wait for a communicative act such as an eye gaze indicating wanting more. And you can keep going. So increasing communicative acts by arranging the environment for something fun, for something to reach for anything to engage the child or the patient with charge syndrome. So in this case, our patient is both deaf and blind. This can frequently happen in a patient with charge syndrome. So in this case, you're not going to have the auditory or the visual stimuli. So we focus on sensory, on touch. So using the water bottle, we could do hand-over-hand procedure to go to the water bottle, maybe shake it around to get that sensory of the water moving around in the water bottle, and then take it away. And see if the child or patient is able to request for it again, to reach towards where they were for the first time, to go for the water bottle again to get the same sensory sensation they were feeling earlier with the water moving around in the water bottle. So this could be a form of communication, and you could work on things like that with a patient that is both deaf and blind.